She's the director. She's the director of the Center for Equity in Aging and a professor in the School of Nursing, as I just mentioned. She has joint appointments in the Department of Health Policy and Management and the Division of Geriatric Medicine and Gerontology in the School of Medicine. She received her PhD in epidemiology from Columbia University, and she was also a predoctoral fellow in psychiatric epidemiology while she was there. Her work focuses on improving health and health care for older adults with serious illness and their caregivers, with a focus on advancing equity. She has over 170 publications, and she's recognized as an expert in home-based care delivery, family and paid caregiving, dementia care, and healthcare delivery at the end of life. Her research work includes downstream effects of economic effects of healthcare and bereavement on families and caregivers, and the epidemiology of the homebound population, as well as burden and cost in dementia caregiving and home-based palliative care. She's a fellow of the Gerontological Society of America, where many of us will be going tomorrow and Thursday, and past recipient of the Dan Gilden Creative Investigator Award from the American Academy of Home Care Medicine. She joined Hopkins in 2022. And prior to that, she served as research director for the Institute for Care Innovations at Home at Mount Sinai Hospital and led the Population Data Use and Management Core within Mount Sinai's Older Americans Independence Center. So we are thrilled to have her here today to talk to us more about her work and what she's doing here at Hopkins. I do want to make one quick announcement before I turn it over to her, is that our next seminar series speaker in December will be Dr. Jason Falvey from the University of Maryland. He is an assistant professor in the Department of Physical Therapy and Rehabilitation Science, as well as the Department of Engineering and Public Health at the University of Maryland School of Medicine. And his talk will be Neighborhoods, Resilience, and Recovery Among Older Adults. Okay, so without further ado, I will turn it over to Katherine.
Thanks, Jeremy. Hi, everyone. Thanks for having me here today, those in person and in Zoom land. So I just have to tell everyone that it's especially exciting for me to be here because what I did not include in my intro is that when I was a doctoral student at Columbia, Linda Freed became the dean at Columbia, and she invited me to meet many of the faculty at COA and come all the way to Baltimore and meet her group here. And I think there's only one person in the room that I may have met there, Chinley. But wait, I think Jeremy, if you're on Zoom, you were probably there as well. So
yeah, I think I was there. Yeah,
that's right. So it's kind of exciting to actually be here and speak to you and all of that. But I have to say, I still feel like that doctoral student that shouldn't be there and doesn't know anyone and is trying not to embarrass yourself. So there you go. So I'm really excited to talk to everyone today about this work. And of all the things that I do, talking about the homebound may be one of my favorite things to do. And it's because it's really something that sort of came to me in my work sort of as I watched. Before I was a doctoral student, I worked for the Mount Sinai Visiting Doctors Program as a research coordinator and an analyst. And that was a home-based primary care program. And really what we did is we saw patients and we saw them in their homes. And we talked all the time about how do we support homebound patients. And at the time, even before I became an official epidemiologist, I kept thinking to myself, what does it mean to be homebound? Who are they? How do we define them? How do we count them? It was just in my head the entire time. So it's really one of my favorite things to talk about. So that's what I'm going to share with you today. So let's see if I've advanced properly. Let's see. I'll try it this way. I don't want to mess up. Okay, so I have nothing to disclose. But I will tell you to disclose that I do have a personal investment in this. And probably my interest in this started before my personal experience, but so it is in life. This is my father with my son in 2012, and that's Elijah when he's 4. And this 10 years later, this is my son, Elijah, who's now I guess at that time he's 14 years old and he's with my dad. And I am a caregiver for my father, who is homebound, but we have managed to bring him outside. Elijah is now big enough that he can push the wheelchair and help get him up and work the Hoyer lift and all of that. Dad suffered from several strokes. His right side is paralyzed. So that's why that's his smile that he can do these days. But we get him outside. So he's homebound. It's really difficult, but because I have my son and I'm there and I have a lot of resources to provide for my dad, we're able to get him outside. And he really enjoys getting outside and going out with his grandson. I have updated this picture because people have asked me. It's not 2022. So this is the one I found on my phone. It's 2023, and we only know because my son is now embracing life in Baltimore. So he has his Ravens shirt. And there he is. We still make him push my dad around, and he's still doing well. He's in New York, though, so we don't see him as often, but we do try to make it down there. So I do say that my disclosure is that I have someone in my life who's homebound, and I really know what that's like. And that has actually informed my work beyond most of the reading that I've done, etc. So what I want to talk to you about today is really what it means to age in the community. And in fact, aging in the community is overwhelmingly what people say they want. The most recent data I could find, we see that 77% of older adults say they want to remain in their homes for the long term, as long as possible. Additionally, we see that people also say they want to die at home. That is consistent. That's not just in the US. They want to live at home. They want to die at home. This has always been the case. These are people's preferences. Conveniently, their preferences are also starting to become more aligned with our financial system to pay for these services. So what you see here in this bar graph, and I have my glasses here so I can see it too, is that increasingly we see Medicaid, which is the largest payer of long-term services and supports, increasingly are paying for money in home settings, which we often think of as home and community-based services beyond nursing homes. So increasingly we are recognizing this is what people want, and we are increasingly trying to pay for it this way. Not all states are doing it the same way. That's sort of where it gets a little bit more complicated. But increasingly, we are trying to meet the needs of what people want. So that's great. But what I really want to talk to everyone about today is, what does it take for us to do this? That's great. These are our preferences. We're trying to financially align things. But what does it take for us to do this? And the answer, and I'll talk to you a lot about this today, is it takes a lot. On the left, that is I'm trying to point with this, but you're not seeing me pointing, are you? Okay, I will point like this. So on the left, what you see is a home visiting doctor, and this is actually my friend Teresa Soriano, and she's taking care of a patient in her home. And so what we see here is one form of home-based clinical care that is happening. And a lot of times, as individuals have difficulty leaving the home, their family has difficulty getting them out of the home, this is really what's required for them to continue to live at home. Otherwise they need to be in institutional care. On the other side is something that's really even more important, or we're more likely to see, which is a family caregiver supporting a patient in their home. So this is a daughter of a homebound patient in New York. Often we don't just have daughters, we have sons, we have friends, we have neighbors. And this is also what it requires in order for individuals to age at home. And I should also say, feel free to interrupt me either in person or via Zoom. I really don't mind. So if I'm skipping, not explaining something, feel free. So what I'm going to talk to you about is everything you've ever wanted to know about being homebound, because I have been thinking about it for a while. And I really want to think about what supports do older adults need to do this? What do they currently have, but what do they really need? And then we can maybe think about what work there is to do in the future. The short answer, and sort of, I'm going to jump ahead and say there's a lot we need to make this happen so that we can actually support individuals at home. Okay, so I like to start off with sort of the question I wanted to ask a long time ago, which is, well, who are these homebound people? Like, how do we find them? And it's sort of a tricky thing, right? Because they're homebound, so you don't see them because they're homebound, right? And the way we were finding the homebound is we would look at who was being served by home-based primary care programs, right? So it would be like who would come in clinically or via home health, and we'd say, oh, we're estimating this number of people. But of course, we know that that's just the people who are served, right? That's just the treated sample potentially. We really couldn't figure out in the community how many adults there were that potentially could benefit from home-based care. And we knew it was greater than those who were being served. From the program I worked at Mount Sinai, as well as other programs, we knew there were huge wait lists. We knew we never had the capacity to meet the needs in the community. But it was really a struggle. We'd often use estimates based on estimates of individuals with disabilities. People have been writing about the homebound forever. And, I am guilty of it as many other people. We were sort of making up numbers. So we're not making it up. It was like a pretty good estimate, but it wasn't really based on asking people, are you home? Like, how often do you leave the home? So we went about this. Conveniently, a study that people know about here, NHATS, came out. And they conveniently had a question that seemed like it could work to help us identify the homebound. So we convened a group of experts who were kind of interested in it or were willing to talk to me about it. And we talked about sort of the questions that were in there that were really the questions that were about leaving the house, how often, and who helps you. And together we decided this is a pretty good definition of the homebound. So we used NHATS to estimate and to kind of come up with sort of a typology of the homebound. So we decided there were some people who were completely homebound. That means they never went out. Now, we didn't ask them why. It wasn't about what illness they had, right? That's what's different. It was about how often do you go out of the home? It was really about that one question, really thinking about it. And then we also decided that homebound was not just they never went out, but they rarely went out. So once a week or less, right? That it did, and again, it didn't matter why. We didn't ask about medical appointments, etc. I need to stay here because no one can hear me. Sorry. Okay, sorry, I will not move. So what we did is we estimated it, and we also came up with other kind of, I couldn't help it. And I was like, well, but there are other kinds of homebound kind of categories that are sort of interesting, still are interesting to me. For example, and we called them semi-homebound. So for example, there are people that are get out. And these are people like my dad. Well, in the winter, maybe not, maybe he's homebound, but it used to be people like my dad who could get out at least sometimes, twice a week or more, but never by themselves, right? So that means these are people who have someone like me or my son that can get them out, or a paid caregiver that can do that. So we really, and also just people who need help or have difficulty. So what we're able to do is estimate that there were 2 million people that were homebound using NHATS. And actually, what's really nice is this was pretty much the number we had always been using. We had always estimated it was that amount, and in fact it was. So that felt pretty good. So we kind of continued to do this work. And what was really most important about that 2 million number, we looked at incident homebound status, because we could do this over time, right? And what was really important about it is there are more people that are homebound than are in nursing homes. There are more people that become homebound than enter nursing homes. That is always true over time. So you can see here in the orange, that is the individuals in nursing homes. And you see in the blue, those are people that are homebound. So over time, more people become homebound. There are always more people homebound. And this is really important because we think a lot about the nursing home population. We study them. Want to know why we study them? Well, they're obviously a very vulnerable population with high needs, but we can identify them easily. Whereas the homebound, they're there, we just don't always find them necessarily, right? They may be lucky enough to get home-based clinical services, but we don't always see them. So it's important to recognize that we continued to follow this population. During COVID, suddenly everybody was talking about the homebound. right? And it was interesting, but they were talking about it in a different way. So of course we did look to see what happened with the homebound population during COVID. And not surprisingly, there was a tremendous increase. You can see that all the way in the end. In 2021, 2020, we see this tremendous increase, whereas the numbers had been stable over time. You see on the bottom, the orange represents the total population that are homebound. And you see this tremendous spike that happens in 2020. Not surprisingly, we assume because of various policies in 2020 requiring many of us to become homebound for the very first time. But what's interesting that we started to look at here is we looked at homebound status by race and ethnicity. And what we found here is that we saw tremendous differences by race and ethnicity, such that the group that was most likely to be homebound and most likely to be homebound during COVID were those who identified as Hispanic. And that's the line on the top. And then the next most likely group in the blue were those who identified as Black, non-Hispanic. And we really saw that consistently throughout and consistent with the spike. And I think what this gets at, and really what's important, and we've consistently seen this as we've analyzed this population, is becoming homebound is not just about the illnesses that you have, right? Remember, my dad, very sick man, but he has a lot of resources that allow him to get out and do things. And that, by definition, is what's being homebound is about. It's very much about these social determinants of health, so, as most things are, but it's quite I think a good example of it, but it might be because I study it all the time. So, and then we also looked at this with NHATS, which was simply looking at baseline income. So we looked at incident homebound status for individuals. So we started with individuals who were not homebound, and we followed them over time. And in this case, we follow them for up to 7 years by income quartile. And indeed, what we see that those in the lowest 2 quartiles were most likely to become homebound over time, even after adjusting for all the other clinical factors, frailty, dementia, comorbidities, all the other factors. Simply income quartile had a strong effect in this population. So recently we've actually started to look at some other things in homebound status. One of the areas was something that I admittedly had not previously explored, but someone came to me and they said, have you thought about falls? Do people who fall become homebound? And I was like, oh, no, I don't know. So we did just look at this. Some colleagues at Mount Sinai that I work with started to look at this, and indeed, and we found that 20% of individuals who experienced a fall became homebound. So again, we were able to see people who had not been homebound, who had not previously been homebound, but they became homebound. And indeed, we see increased probability of becoming homebound by fall status, as well as even fear of falling. So again, it really shows you there's a lot that goes into this concept of being homebound that we really hadn't thought about, and that potentially we may be able to modify so that we can prevent homebound status. There's mortality we looked at. As soon as we had data, we were able to look at mortality. Indeed, we saw homebound status associated with a greater mortality in this population. Importantly, too, we found that older adults who were in the community before death, meaning they were not in a nursing home at the time of death, half of them were homebound. So it sort of flips it, but just reminds you to think about it, that this is not an uncommon state over the course of an individual's life, especially as they're approaching death. Being homebound is just not uncommon. Right. So I think that really, for those of us who do work in end of life care and really thinking about this, that is a state that people are in. And we really need to recognize what are the services that they might need to live in this situation. We also have done some work, and in fact, being homebound is dynamic. It changes. We've followed this. We've spent some time obsessing over this. I will let the colors speak for themselves on how dynamic the state can be. But we've also been specifically interested in dementia status and how it may impact transitions in homebound status. And indeed, dementia, and what we found in clinical samples related to being homebound. So in populations that are serving the homebound, we consistently recognize that about a half of the sample have dementia. That's sort of understood in home-based primary care practices. And we actually do find, maybe not half, but we do find a very high number, maybe 30 to 40%, depend on the measures that we see in national samples as well. So dementia status is a big part of being homebound as well. Indeed, having dementia is different. Sort of how you move through homebound states matter. And indeed, we see increased probability of death for individuals who are homebound with dementia. So again, this is important for thinking about what the care needs are for this population. So recent work that we did, we actually started to consider whether the homebound is just too big of a group. Like maybe we can't serve this population because people are homebound for different reasons. So we did a latent class analysis to try to better understand the heterogeneity of this population, thinking about whether we can serve them in different ways. So we looked at newly homebound individuals between 2012 and 2019, basically thinking about at the time they became homebound, what were their characteristics, and can we see sort of different groups emerging? We did see different groups emerging, and we're still sort of underway with this kind of analysis. Which is looking at those who maybe have less impairment overall, some who are really very high symptom burden, and some that are really just like a lot of a dementia group, you know, like really, and then finally the last group, and I can't see it, my apologies, are those who are in assisted living. So, and that are older. So we are seeing sort of a group, sort of where they're living, how they're, you know, sort of, and we can definitely think, we looked at these groups relative to mortality, as well as other outcomes to try to think about whether there's better ways of serving this group that are homebound. Okay, so what's important about this and why people really care about this right now is that it matters for spending in a big way. So we've done some financial analyses on the homebound, and it's not surprising. It actually completely makes sense, which is that homebound older adults are less likely to go to primary care, specialist care. But what they are doing is they are going to ED visits. They are going to skilled nursing facilities. They're getting more home health, right? Because it's harder for them to access primary care. And indeed, those things cost more. So if we simply look on the right in the bar charts, and this was done with NHATS data linked to Medicare claims data. So this is a fee-for-service population. You can see that this is, you know, there's greater spending in this population. But by looking at the fact that they are less likely to spend in primary care, specialty visits, is getting at the fact that maybe we can actually do something, right? So people actually care about this. Well, we recognize they're homebound. Maybe there is something we can do to potentially lower cost down the road. Okay, so we have actually, this is really exciting work that we're doing, is we're finding other data sets to measure homebound status in. And this is pretty exciting for me personally. In fact, I work with some groups that study traumatic brain injury. And in fact, they have a measure in there. They didn't intend to think about being homebound, but I reminded them that they could think about it. And so through the TBIMS national database, I don't know if anyone knows that group or what they do, but they actually are able, they have facilities throughout the US where they collect information on individuals who had traumatic brain injuries. And what's really important about this is a lot of the work that's being done in brain injury is very much focused on getting home, right? If you can get people home and out of a facility, like you've done your job, you're a success story, or that's sort of how things were, they thought about it. However, they do have a question here. which is in a typical week, how many days do you get out of your house and go somewhere? It could be anywhere, doesn't have to be any place. Someone put this question in, nobody really knows why, but it's in there. And what's interesting is, of course, nobody had looked at this question previously, but it sort of raised this whole issue among this, large research consortium, essentially, of, well, do we want them home or do we want them leaving the home? Right? Does it matter that they're home? Is that our goal for everyone to get home, or should we really think about it beyond this? So we've just done these analyses. We haven't published these yet. But in fact, homeboundness affects mortality among those with traumatic brain injury. In fact, we see 5-year mortality rate is about 23% among the homebound versus 9% among the non-homebound in the sample. So they're just starting to look at this. And it's really exciting because it's sort of shifting what people should think about, right? What are the outcomes of interest in this population as well as other populations? So I hope at this point I've given you a sense of pretty much everything you've ever wanted to know about the homebound. It's my goal. If I haven't, talk to me afterwards. I'd love to talk about it. But I really want to kind of shift from there and think about, how do we actually support individuals in the community and what do they need? So in thinking about home-based care and what it is, right? There's actually no clear definition of this. This is something that I've discussed with my colleagues endlessly. Well, what is it? Well, it depends who's paying for it. That's what it is, right? So we often think of it based on home-based clinical services, right? That's the blue. And then the white is sort of everything else. We kind of call that long-term services and support. So the reason it's sort of broken up this way, I think essentially is because that's how we pay for things, right? So that's sort of, it's not the way like it works. It's not from like the perspective of like my dad, what helps him function, right? It's just sort of our payment system, essentially. So when we think of home-based care, in the blue, you see clinical care. So what is that? Well, I mentioned sort of the home-based medical care, right, that we have, that most people don't have. In fact, even if you're homebound, 10% or less will get home-based medical care. Home health care is our most common type of home-based clinical service that we get. So that's based on a skilled need. A nurse, social worker, physical therapy, occupational therapist will come into the home, provide services, but it's based on either post-acute skilled need or a need identified in the community. And then there's other services paid for by Medicare that are home-based. Podiatry is a big one, actually. Home-based podiatry is something that happens, and I will put in my plug, and I always do. If anyone is interested in podiatry, please talk to me. There's a ton happening because we've been looking at all these Medicare claims on podiatry, and there's really a lot happening. Podiatrists are doing a lot of work for patients who are homebound. Like somehow it works for them as a payment model, like it's happening there. I don't think we study it at all. There's a lot of data around it. I think it's potentially a really important opportunity. Anyway, so I have to put in my plug, can't control myself, but there's actually a lot of other things happening that we see being billed in the home all the time. Behavioral health services, lab work, imaging. Of course, hospice services are home-based services for the most part, not all, but most of hospice is happening in the home. So these are all sort of home-based clinical services that are covered via traditional Medicare, essentially, and long-term services and supports. It's all this other stuff. And there's no real clear definition about it. Sometimes we call this like home and community-based services. That's when Medicaid covers it, and that's sort of what they're calling it. But it's really all the other things one needs. And this is sort of one way our group has divided it, but there's not a set way of doing it. But you can think of different accommodations. You can think of the Capable program and sort of the supports that they might provide. You can think of caregiver support. That's a huge part of it, right? But that would be not just the family caregivers, but paid caregivers. Residential support services. So we have assisted livings, but we actually have all different kinds of new types of things popping up there that we have no idea what they are and what they offer. And then anything else, transportation, Meals on Wheels, all of this is home-based care, right? And all of this, many would argue, are potentially more important than some of these home-based clinical services, although they're not generally covered. So we've done a lot of work now that we've thought about who's homebound and what the needs are, of really trying to understand who gets home-based care, what are the determinants of that, as well as outcomes of home-based care delivery, and thinking about patient outcomes relative to healthcare, relative to social isolation, quality of life, certainly cost around being receiving home-based care, but also caregiver outcomes are really important as well here. And again, I think I've made this point already, but just home-based clinical care and long-term services and supports, just there's a lot of things there. And we've actually just published a paper on this, again, using data from NHATS, where we actually tried to like make sense of it. We were like, okay, who's getting what? Is one person getting everything, or are there different patterns of it? Blah, blah, blah. The quick answer to this is most people aren't getting enough of anything. In terms of home-based, so these are among people who are homebound. We have 30% are getting any kind of home-based clinical care. And that most often is skilled home health care, right? And that's really been like the, that's the main kind of home-based care people are getting. Again, home-based medical care, where people are actually getting in-home services, primary care, which by the way, my father does get home-based primary care. It's just not happening in any way. Home-based long-term services and supports. This is one way we've tried to think about it using data from NHATS of just like, what are the things that people might need? The most common thing we see are assistive devices, but that's kind of broad. That's, in some ways some could be DME paid for, but it's sort of, they're very broad. Paid care, again, among the homebound, a little bit more than 20% are getting some kind of paid caregiving support. We looked at whether they have a lot of family caregiving and so on. So things like Meals on Wheels, really not happening for the population, very low. And then on the side, we were messing around trying to identify different groups and so on. That's an ongoing fun project. So I mentioned a little bit about dementia, and dementia is pretty important in this population because again, it's actually a large group with dementia, and their care needs are different. And what's exciting is there's a lot of new service models being designed for patients with dementia, because we're recognizing there's such a need. So it is important to recognize, and there's also sort of, for the most part, more of a long-term need in the community for this population. So we've done a lot of work looking at how some of these services vary by dementia status. And indeed, we see huge variation. The biggest variation is that you're more likely to get home-based clinical care if you have dementia in a huge way. We see it across home-based medical care. If you have dementia, you are far more likely to have this. If you podiatry, you're getting actually a lot of podiatry. Again, I'm sorry, I'm totally obsessed with it. And skilled home health care, we're still seeing with people with dementia far more likely to get all these home-based services. Not only that, we're getting them in little different ways that are actually important for payment too. This is work we did, and we joked that we started this study in early 2020, and we thought that the payment changes for skilled home health care were going to be like the most exciting thing to happen in spring of 2020. But they weren't, and no one paid that much attention. They're thinking about them now. The data are out now, so now we're studying them. But it was kind of like at the time we were like, oh my God, this is such a big deal. But somehow something else happened in 2020 to distract us all. But one of the things that we found out in looking at this, and this was a concern we had, which we are now going to try to start studying, is in dementia care, what we realized, skilled home health care, which I mentioned, is like really common in home-based clinical care. Like that's what we get. And we most often think of it as like, you have knee surgery and then you need someone to come to the home and help, or you have wound care needs and so on. And that's sort of more of the traditional post-institutional or post-acute skilled home health care. For dementia, they're much more likely to get community initiated home health care because they're in the community and that's where they're getting it. So that's a real different, and what's critical about it is they're changing the payment for these things, or they've already changed it. So we're actually getting paid less for community initiated home health care. So that matters for sort of dementia care delivery. So I also want to talk a little bit about access to home-based medical care. I've already given it away and I told you it's limited, right? Because you probably know it's limited because how many of you have like a home visit doctor that's coming over, taking care of you and your family? So, well, Thomas is here and you have free time, so you're happy to. Right, so you know it's not normative, like it's not there for everyone. So we've started to look at it. One of the things we've thought about, I'm involved in the American Academy of Home Care Medicine, and we keep seeing that there's sort of a lot of this sort of changes happening. A lot of people are sort of moving into sort of some of these private companies and there's sort of different things happening in the Medicare Advantage space. So we've been really curious about, well, is that what's happening? Are they doing all the home-based care? Are they kind of coming in and doing the assessments? And this is work that was actually led by Jeff Marr, who's a doctoral student here at Hopkins. And we looked comparing home-based medical care delivery in fee-for-service versus Medicare Advantage. And what we saw that was actually really important is in Medicare Advantage, which is the orange on the right, is they are really good at doing one in-person assessment that they're billing as home-based care. They're really good at that. But they're not doing what we see on the left, which is longitudinal home-based medical care. And longitudinal home-based medical care is what we think of as needed, right? Like my dad doesn't need one visit once, he needs someone to come in and take care of him every couple of months and serve his needs as a primary care doctor. So what we're seeing is MA plans are not doing it either, but they are doing it one time. So there is some concern that this may be a billing issue, that we're trying to do some good coding, but I certainly won't pass any judgment on that. So there clearly is still some work happening. I think what we do see is there's a real opportunity. Home-based medical care, at least Medicare Advantage, at least has workforce potentially able to go into the home and do this, right? They're just not doing it in a sustained way over time. We've also started to look at just access throughout the US and over time and sort of trying to understand what's happening in home-based medical care. What's really been interesting about this, and this is something we've discovered in doing this work, this is just using public use data, public use files that we can actually capture on just Medicare provider utilization payment data. And in doing this, we simply looked at who's billing for visits at home. And what we saw is that the growth that we had, again, thought about within our home care academy and recognizing that more seems to be happening, what we realized in doing this is that the growth was actually not happening in private residences. The growth is happening in what is considered domiciliary settings. And domiciliary settings are assisted livings, group homes, all sorts of kinds of congregate settings, essentially. Now, this makes sense, of course, right? Because if you're a provider going into someone's home, like you're not billed for your travel time. You're not even billing that much more for the home visit relative to an in-person clinic visit. It's not worth your while, right? So of course it makes sense that this is happening. But the reality is we actually didn't know this was happening until we looked at the data and we saw, oh, indeed. And it was really just because you're able to capture it in the billing codes that you use. It's like a slightly different code in your claims data. And we've also been starting to look at variation in home-based medical care as well as home health care and relative to level of socioeconomic deprivation, recognizing that there are really some areas where there's no home-based medical care and there are high socioeconomic deprivation via, this is county level. So really there's some concern about areas that are not being served well. So I want to talk about, so that's sort of most of what we know about home-based clinical care in a nutshell. But what I want to share is really talking about families and family caregiving, because ultimately they are the main sources of support for the homebound. And they are, really the key to our long-term service and support system. And I think they actually can help facilitate home-based care delivery, right? In the way that we know that they can be advocates in different ways. They're actually helping patients find the care that they need. So we've done a lot of work to try to understand what types of support adult child caregivers provide their parents. And I think what's important here is, and this is data from the Health and Retirement Survey. And so what's important here is recognizing, well, what is support for families to provide? Like, what does that mean? And, I think a lot of times we assume it's like helping with bathing. Well, that's a pretty big deal, and not everyone is capable of doing that. But really, a lot of times it can be helped with functional support or different kinds of needs in the home. Shopping needs and so on. But what we've also thought about is that really some of the needs are financial support. There's a lot of families that are supporting individuals just financially. And we also recognize that co-residence happens too. And sometimes co-residence is a benefit for the caregiver, not just the patient necessarily, right? In different situations. So we've done some work starting to really look at this, and we see differences by dementia status. Again, the needs of dementia can be just longer, more extreme, more physically taxing for individuals. And we've also started to look at this with differences by race and ethnicity. Just really thinking about, what does it mean to be a caregiver? It's something that's like, it's not a clearly defined thing. We have certain definitions we use, but I posit that one should really kind of think a little bit more broadly about what that means. I don't, probably don't qualify. I don't do any physical, hands-on work for my father, but, I'm definitely a caregiver. I am behind the scenes doing all this stuff. I don't live with him. I don't do, but, one could never argue that I wasn't providing that support. So I really do think there's sort of a lot happening there that we don't always see, and it really varies. And one of the sort of issues I would like to just sort of mention in that we've started to do work, and this is work that Kate Miller here at Hopkins has led, is actually thinking about variation that's based on sort of access to care and services. So your family, there's sort of this, expectation like, oh, well, yes, we all have family. And that's not true. We all have family readily available. Not true. We all have family that live close by. Totally not true. And then if we don't have family, well, there's workforce readily available to jump in. Totally not true. And we do see that this is a real concern. This is work that we did with a Health and Retirement Survey, again, looking at sort of who has family care, who uses formal care. Formal care is sort of paid care, who has both. And we just see real differences in availability. And indeed, in rural areas, people do not have as many family there. They kind of say that they expect to use nursing home care more because they don't have family. And we are especially in a crisis of not having enough paid caregiving workforce available to support them. So that brings me to sort of this other topic in family caregiving that I like to think about, which is being kinless. And I made this slide because I was about to give a talk on family caregiving. I guess it was about a year ago. And then like all of a sudden, Paula Spann writes this article like the day before on kinless adults. So I had to put it in because I was like, oh my goodness. So I was very excited. But the idea is, it's now something that people are recognizing, right? We are recognizing demographic changes in family caregiving. And this is important because, as I said, we are relying on family caregivers. We're totally relying on them. But guess what? Not everyone has immediate family. Again, ready, willing, able to do it, right? But so this is important. And I tell every student, you can't study caregivers and not think about people who do not have caregivers, right? That's a big deal. So we've looked at this for individuals at the end of life, looking at a health and retirement survey. And indeed, traditionally, when we talk about the kinless, it's sort of a term people don't like. I don't really like it because we think of traditional kin. Traditional kin are children and spouses or partners, right? And we know that that's not all the people, sort of the family, the chosen family, or even the extended family, or the neighbors, or the support system that we have. But a lot of times we still think about traditional kin. Well, the reality is, at the end of life, we see about 10% of individuals with some variation by gender that we've looked at don't have any, none, right? They're not even there. So that's really important. And then this is in the US, and this is changing. We are moving in directions where we'll be increasing in that way. And we can see this because I've done some work on this in Denmark, and where they've have smaller family sizes in general. And we see more, this time we see 14% in Denmark in the last 10 years that don't have traditional kin. So it's really important to recognize that this is happening. And at least in the US, we see that this may be more of a problem for some individuals than others, and for some subgroups. We may be really concerned. And again, important because we're relying on them. Like, we don't have a backup plan, really. Like, we don't know what to do if they do not have someone advocating for them. So we've started to do some work to try to understand what does it mean for outcomes? We do see differences in outcomes relative to whether or not you have family, right? And it makes sense. It's the same sort of way that we think about family as advocates. And we know that matters in healthcare settings, right? And what's fun is I will share with you guys is we're actually doing work around this in Utah. And the reason that we're doing work in Utah is because I was telling some colleagues about the work I was doing in Denmark. I was giving a presentation, and they were from the University of Utah. And I was showing them the families, and I said, look how many families we're identifying, and these people don't have families, and these people have this many families. And they said, well, why don't you just do this study in Utah? And I was like, what do you mean? And they're like, oh, we have all these data in Utah. We collect everything. And I didn't know. I had not been to Utah at the time, but Utah has what's the Utah Population Database. I don't know if anyone here has heard about it. Maybe they've, yeah, okay, all right. So basically it started through the Church of Latter-day Saints. They started collecting information on families, and then they started linking it to everything because they could. So this was before we all talked about linking. They were linking. They did a lot of work in cancer, a lot of cool genetic studies. Our group has now started this new caregiving research group through the UPBB, we call it CPOPs. And what we've done, the first thing we're doing was just replicating some of the work we've done with HRS, as well as in Denmark, just looking at people at the end of life, how many family members they have, and you can identify them. In Utah, you can identify them. It's sort of via, if they go to the DMV, they track it. You can have all the claims and things like that, but you can track everything, and we can see adult children, siblings, parents. So we're doing some work on this there now. It's particularly interesting because they have a really big rural population, so we can actually look at some rural differences there. If anyone's interested in Utah, come talk to me. There's a lot of work there. So just in closing, and I promise I am closing. I do want to just talk about COVID and home-based care, because I would say that it really, I don't know, I like to think of COVID as that we learned something in the process. And I felt like I did, specifically because there was so much around being homebound and home-based care delivery that just hit me, and people asked me about a lot. So I don't usually write editorials and things like that, but I did, because I was really kind of like hit by COVID in certain ways. And there were certain things that I thought about. And just a couple of things I thought about, both during and after, was really thinking about family caregiving and really how hard it was during COVID and that experience. And then also home-based primary care as something so important. And what do we learn during COVID from this process? So I just hopefully we'll share some lessons from you that I took away. And so we did some studies during COVID, trying to understand the experience of being homebound already before COVID. And I think what's interesting is, in some ways, it was always as hard, right? If you already were homebound and then COVID happened, if anything, it just emphasized what was already challenging in these situations, which is sort of this, in general, many people who are homebound, they're trying to avoid the emergency room in the hospital. But of course, there was increased urgency in the process. And I also think just the caregiving experience became long distance. But I think the caregiving experience is always challenging. Caregivers always want to do more or have more time for a person with serious illness, such as dementia, but they don't. And they have to substitute either a paid caregiver or someone who is less experienced, or a very kind neighbor, who we did see a lot of in New York during COVID, when we had many caregivers who just weren't available to support homebound patients. And, we did a lot with telehealth, and we've been thinking a lot about telehealth since COVID. I guess a lot of people have been. So at the start of, when I was in New York at the start of the pandemic, the XCC was just like offering, we want to give you money so you can do something, and you can do, we'll give you money, da, da, da. So we wrote a grant, because that's what you're supposed to do in these situations. And they gave us all this money, and they're like, just buy some kind of thing so you can do telehealth. That was basically the instructions, basically what we wrote that we were going to do. So we said, okay, we have this home-based primary care practice. We're going to buy everyone these devices. They gave us all this money. We're going to give everyone a device. Okay, we can do that. They gave us money. They, of course, didn't give us any money to do any evaluation or to thoughtfully do things. They just gave us money to buy equipment, but we took it, right? So conveniently, at the time, we had some medical students around who, because of COVID, couldn't do their planned lab work. And so they came and they said, can we help? I said, oh yes, please come help us. And so we did a lot of surveys of trying to understand, who are our patients? If we gave them a device, what would they do? How do they use a device? All this stuff. So what came out of that was that most of the patients who are homebound, they can't use a device. They cannot use a device on their own. They require assistance from a family member and or paid caregiver to remotely engage in a device, even if it's the fanciest thing or whatever, top of the line thing. I mean, I guess that seems obvious, but I mean, we had no idea. And again, they were just giving us money saying, give it to them, just give it to them. This will solve the problem. But I would say successfully, we did get about a third of our homebound patients in a practice of about 1,000 to actually do video-based telehealth encounters using these devices. So we really learned a lot about sort of how to deal with these problems. And I would say telehealth again it's just not a solution. Home-based care delivery patients who are homebound, telehealth can help. We can get there, but there's a lot you have to think about to make telehealth happen. And even telehealth can be dependent on the family to be there and to support it. And we even, in recent work on this, we realized, I can't remember what we called it now, but you can do that and you can teach them, but then you have to reteach them because, a couple of weeks later, no one knows how to use it and we have to kind of go over it again. So that has to be part of the process. So, there's been a lot of work in really thinking about models of care needed to support homebound older adults. There's really many different types of needs throughout that I've been thinking about and many of my colleagues have been thinking about. I think it's actually an exciting time in home-based care delivery. I think COVID at least reminded everyone to think about it, what it means to be at home and what the challenges are. And, food delivery is not a crazy thing to have anymore, and you can deliver everything now, but to really think about what those needs are. And I think that is positive. We can leverage that essentially. So I think this might be close to my last slide. So what do we need? Reminder, we are going to see growth in the homebound population. This will be fueled by dementia, but it's not just dementia. Many illnesses, situations result in being homebound. And again, telehealth is not going to solve all of our problems with being homebound, but we can leverage it appropriately. And I think we do see marked differences in this population relative to who has access to home-based care delivery. And we really need to do more around that. Really trying to understand Medicare Advantage does not seem to be solving it. They could be, but they're not yet. So we really do need to understand who's getting, different types of care. There's a lot of new and exciting programs happening in different states, different models we're starting to test. We'll really need to think about who's able to access them. And again, family caregiving, no matter what we come up with, family caregiving is still going to be there. Like, we're still going to support individuals as they age, and families are going to be needed in the process. So I just want to acknowledge my funders, but more importantly, all of the colleagues, students, mentors and this is not all of them, of course, but many of them who have supported me in this work. So thank you. So I would love to take questions. Yes, Kyle.
Thanks for this great presentation. I was wondering, you showed the figure earlier with the really stark increase in homeboundness. I was wondering, sort of now we're 3 years after the start of COVID, has it gone down sort of to the previous levels, or has it?
Excellent question. If someone wants to work on that analysis with me, I think we have I think we have 2021 data already and 2022. So yes, let's do it. We haven't looked at it. It would be very interesting to see. But yeah, it's available there. So we can really look at that.
Could you repeat the question? Sorry, I couldn't hear the question.
Oh, sure. The question was whether we have looked since 2020 at changes in the homebound prevalence using NHATs. And in fact, I have not done it yet, but I would love to do it. It would be easy to do, and we should definitely look at it.
I have a question, if you don't mind.
Sure.
This is kind of somewhat based on personal experience. My mom lived in a home in rural Ohio, and this sort of telehealth experience, it wasn't a telehealth device, but this GrandPad. I don't know if you're familiar with those. It's a company that has these they look like little iPads, but they have a lot of ability to interact with people, so you can talk to your family. And this was all happening during COVID. And I have to say that particular device probably kept her in her house an extra 2 years. I would say, just because we could communicate with her, my sister could. And it wasn't easy at first, but with a little practice, I think it really did help her, think we were around nearby all the time. And if she needed something, she'd call us on the regular telephone, but we would often have these video, chats with her. And later then we did do some of it with her healthcare providers, which I think was helpful. So although I wouldn't say it's the absolute right thing. It's a good, star next to the, healthcare intervention. So, and then the other thing I was going to say, we have this new AI technology grant that we're leading over here. And there's a lot of new technologies that I think would be super, super helpful in this regard. So we should definitely get together and chat about that soon.
Yeah, 100%. No, thanks, Jeremy. And I would say that I do think there's a lot we can do with technology but it has to, I think we really need to recognize how to make that available for everybody.
Yeah,
it was very shocking to our group when we realized that people just, in fact, we had several groups where we had done this survey, and nobody had surveyed patients, to even ask them when we were starting to set up telehealth. And we were like, they don't know what they're doing. It's like now, how they realize, oh, wait, not everyone knows how to use my chart. Who knows how to use my chart? Who doesn't? Who's able to use it? It was like people were not realizing what was happening there. So but I do think it is important. The devices that we ended up purchasing could do so many things, right? We could, attach, blood pressure cuffs and do all these cool things. And it had been from our hospital at home program, and that's why they were chosen. But the reality is, I think having one where you could communicate with family would have been way more useful than some of these fancy things. So I think we need to think about that. We're wasting time with all the things you can do, where make it simple in a way. And but you do have to talk to the patients and the families about what they need to get
Yeah.
it right. Because at least the administration at Mount Sinai, they had no idea what they needed.
And it's probably also very diagnostic specific too. I mean, we do in geriatric care over here. I mean, they're just, hundreds of different diagnoses that will keep people at home, right? Or and some of them you're really able to do some of these use some of these devices, some people, but others are just, it's not ever going to be possible. So I think it can't be this broad general thing that's pushed out to everybody. It has to be, rather specific and precise, I
Right.
guess. Yeah.
Mhm.
Okay,
Yeah.
thank you.
What did you give them? You recall, was it
I think it was
a
these,
tablet and something else, or?
it was a tablet-like device from the Vivify company
And
that,
then were there other attachments? that
there were
supposed to help measure
attachments.
things?
Yep.
Okay,
yep,
it's interesting.
yeah.
But it wasn't simplistic. So I've heard of the Gram pad that Jeremy was mentioning. I don't know if you can hear me or not, but and in fact, Frank was looking at using them in Achieve because his trial got interrupted by COVID,
Mhm.
but then luckily they were able to start visits again. So he never had to use them, but they are supposed to be simplified for older people, but how simple, I don't know. And if it's more of a communication device than a measurement device, I think.
Right.
Right. And so
Right.
it sounds like what you guys were trying to do is actually take more vital signs, I think.
I think
perhaps.
that's what we were basing it on, but really, just to facilitate a visit is
Yeah.
all we were trying to do, is to let them have a primary care visit. But we went with the one that, we could also check their oxygen, and we could,
Yeah.
we wanted to do
Right.
all these cool things.
Right. they
but
couldn't-
It was too much. And we were also doing it, we had to have a cellular plan as part of it and so on.
yeah.
And we found it was so, we were relying so much, and it could be, this is a very sick population, very seriously ill population, a lot of dementia, so you're relying on caregivers. And in this case, you're relying on paid caregivers. So a lot of times that's also a lot of learning, a lot of health literacy and technology literacy issues as well. So it was very complicated in terms of what to use. Yeah, Marcella?
So, a question is about connectivity. Who pays for that? The patients that don't have.
Yeah, we always covered it. That was part of what we did, which was why it was very expensive, because they don't have good connectivity.
So what about after you're gone?
Right. And that's a huge issue in sustainability. Oh yeah. I mean, there was a whole, there was a whole effort gone to just collect the devices again and get them back and get them out of the house, and which, some will just disappear, as you guys, it's like a whole thing. But yeah, you have to have the connectivity as well, to make it work. So again, for some people, life's it was amazing. Some people it's even better, right? Because then I love it when I can do a visit with my dad on a device, because then I can be there. Whereas normally I'm not there for a visit, but it's like, oh wait, I can join this visit as well as him and his paid caregiver. That's ideal. But again, who is that ideal for? It's me, so it's like, again, we're not serving everyone in this situation. Yeah.
I was wondering whether you were able to open the payment model for podiatry, make that healthcare delivery more sustainable and reimbursable.
As soon as I find a podiatrist or a student who wants to look at it, I am there. And the reason I'm there, I'm serious about it. It's kind of a joke. I'm like, oh, podiatry, but it's because it's happening everywhere. People are billing. And the reality is, when you think of social isolation, someone is coming to 10% of patients with dementia have a podiatrist, at least billing, coming into their home and doing work on their feet. And I think all the geriatricians in here know how important that is for, care. So I don't know if it's their model works better. It's a shorter visit. I don't, I haven't looked into it because they're doing different procedures in different ways, but they're doing it all over the US, podiatry. So I don't know. Yes, Thomas.
Thank you for your presentation, all the work that you've done to date. I'm curious to know whether or not there's the potential to examine the percentage or the impact of those who are homebound that are homebound, not for physical reasons. Like I guess the reason I think about it is because, you know, that physical part of things and could be mental health care, dementia, reasons why people are homebound, but also like this piece of like motivation. Like I guess I'm as a veteran myself and getting care at Walter Reed, I see people who have no limbs getting, you know, moving about out and about. And so I guess I kind of juxtapose that to this challenge and then the care that I give people and knowing that some of the people could not, you know, could get out and not necessarily be homebound. But I don't know how we would actually examine this in a thoughtful way to really understand, you know, the dynamic nature that you demonstrated. That, you know, how can we get people out of being homebound?
Right.
If it's so dynamic.
Yeah, no, I think it's a great question. I think we were trying to get at that a little bit by looking at the different groups, you know, to really try to see that. I think, you know, like a lot of what we know is really based on clinical practice from people who, again, have patients who are in home-based primary care practices, right? So that's sort of what we know, but what we're seeing is like, there's this dementia group, you know, but then there's also just like a group. And my mentee, Harriet Mather, is still looking at this. They're not that sick. You know what I mean? Like, oh, okay, there's some comorbidities, but they're not that impaired. What else is going on there? So I do think we could try to look at it. And if we, you know, are able to kind of collect patients as they become homebound, which is sort of how we've set up some of these analyses, we are getting more and more patients. So we can look at some of, you know, what's going into it. You might be interested in the work that we're doing with the TBI population as well, because they have a ton of data that they collect there. And that's part of why I'm excited about that, because we never looked at that either, right? Because we don't have a question about that specifically. But that's part of why we started looking at falls, because we're like, what is happening to trigger this essentially? So I do think there is a lot to consider, because it's not all dementia. It's not all, but we do see like they're very sick. Like mortality is very high in this population, but they're not hospice eligible. They're not dying in 6 months to a year, you know, for the most part. So they're living at home like this.
Katherine, thank you so much for this talk. It was really fascinating. One thing I was wondering about is what's known about how homebound people self-report their own health? Like, how do they perceive their health? And have you also thought about like this idea of like patient prioritized care, so helping people identify their own goals? Meaning, are homebound people, is their goal to get out of the house, or do they just want to be healthy in their house? So I'm just curious if any of the work's been done.
Yeah, it's a really interesting point. I'd say we have looked at self-reported health, you know, for the population as a whole, and generally they're for the most part pretty sick. But I do think it is interesting to think about, well, what is an individual's goal, right? You know, sort of in the beginning, I said everyone wants to age at home, right? They want to be at home. Well, what does that mean? Do they want to stay there? Like, what is ideal, right? For many patients like who are very sick, that's it. Being homebound is okay, right? Like, we can't necessarily expect more, essentially. But you know, I think it does make you kind of question it. Like, is homebound the work? Like, it's like we always think nursing home is, you know, oh, we don't want nursing home. Well, that's not true. For many patients, like the nursing home is appropriate care for them, and that's what they need, and they may have very high quality of life. So I think you're right. It's sort of what are the needs of an individual there. And I think I do try to, you know, it's important. You're right in that it's important to think about, like, is this positive or negative? I think what's important is just to recognize that that's happening in the population and so prevalent.
Thank you.
Yeah, thank you.
I think it would be interesting, like tagging on to what Brian was saying, in some of this work, I agree that people want to age at home, right? They don't want to go to a nursing home, but are they getting what they need? Are they still bathing, right? Are they still getting out of bed every day? You know, these kinds of things. Are they doing the basic self-care? And I don't know, I'm sure there's a way to quantify that. I don't know if that's
Mhm.
anything you've looked at or.
Yeah, we have looked at it. There are many unmet needs in
Yeah.
this population,
Yeah.
for sure. It's hard because this is like the sickest population. You know, it's sort of very difficult in a way, but there are many unmet needs. That's part of why we've started to look at home-based care as sort of, what does that do? So if we provide the services to individuals, if we give them clinical care at home as well as paid caregiving support, you know, does that improve, you know, anything for them overall in terms of looking at like days at home and quality? But it is hard because it is, you know, back to Thomas's point, it's a population that really, it's big in terms of who is there. You know, we also have a large population who we have patients who are obese that are homebound, you know, they're younger homebound. We have psychiatric illness, you know, sort of a population that's primarily why they're homebound, a generally younger population there too. So it's, you know, their needs are very different.
I would say that there's, you know, also about large data analysis, we also have opportunities in our own health system, because of the, you know, home-based primary care that we have and the data that exists in that.
Mhm. Yeah,
You know, what are we doing here with it?
Right. But I think what that gets at though is that we don't always know that, right? This is not something we routinely measure. I mean, we don't even routinely collect information on functional status for patients, right? That we know. So we don't even know these things, and we don't know how often they leave the home or if they want to leave the home and they're unable to because they need a ramp or, you know, potentially. So we don't collect information like this.
Here's the, I mean, I haven't surprised nobody brought up frailty, it's between being homebound and
Mhm.
frail, is this,
Yeah, they're very,
two the same, or what would you say, or is there been work done to examine the relationship between the two?
I mean, we've generally looked at it and they're a very frail population, but we haven't really kind of specifically examined, you know, sort of that group, you know, or specifically kind of get out there. What are you thinking as sort
Yeah, I
of?
mean, I guess some of them may not be frail, right? Because
Mhm.
homebound. But
Mhm. So look at the
it's
homebound who are
popular.
not frail and try to understand them from that perspective, potentially. We certainly could do that. Yeah, we looked at frailty in terms of the falls work that's ongoing now. We've started to look at frailty more there specifically.
I think one of the key here started to look at that she's here.
Mm.
Like the cold room, sorry. Like
Oh, yeah.
resources upstairs, but
Uh-huh.
I was thinking the same question.
Oh, okay.
We'll work with you.
Well, if anyone is interested in studying the homebound, again, we love to talk about it.
I look at it, some kind of leniency factor in intervention by frailty status within the population. Right?
Yeah.
Because we consider frailty as an indicator of lack of reserve or resilience. And that's an interesting question. I know there's RFA trying to better understand heterogeneity, exercise intervention and responsiveness. So you should think that concept applies to everything.
Okay.
Because I mean, ultimately, I guess you'll have to prioritize resources, right? Assuming the resources are limited, and if you wanted to target these people, the homebound, so how to prioritize?
Mhm.
So is it right to take into account the capacity to potentially benefit,
Right.
right? So I
Mhm.
mean, I don't know. I mean, it could go either way.
Right.
Frail people will benefit the most, right? So I mean, I'm not saying they will benefit the
Mhm.
least,
Mm-hmm.
but it's important to find out.
Right. I see what you're saying. Right. And I think that's a great point because people, like, the thing is, people care about this population because they're really expensive, right? And we're showing that consistently, you know, so they really care. There's a big concern. And again, this could be the nursing home population, right? So it's not, but they're really as sick, you know, so I think that's a great point.
Speaking of the caregivers of people who are homebound, like, if you're like research with their like profiles, like, I assume that they're probably like having greater intensity of care, and also like does the characteristics differ? If you're caring for someone who's been
Right, if they're doing more work like with transportation or things like that. So we've done one study at least where we've published looking at like from a clinical, population where we've actually looked and found out the needs of our caregivers. But I don't think we've done it for all the homebound, like using NHATs and NSOC. I don't think we've done that yet. Specifically, because I think you're right, what they're doing is likely different, but it also, we still have the issue of the heterogeneity of the population, right? Because again, half the people before they die in that last year, they're homebound. Homebound includes bedbound in a way, right? So that's an individual who, at the late stage of illness is dying, they're also homebound. So it's tricky that way, but I think that could be interesting work as well. We certainly could do. Yeah. Okay, well, please don't hesitate to contact me if you have any interest in this or other ideas.
Hey, Kathy, this is Adam Spira, and I realized I should probably say something because you're not in the chat. I mentioned that as someone who studies sleep, I worry about the sleep of these folks because there's potentially a total absence of bright light to help jumpstart their circadian rhythm, and they have low levels of physical activity and potentially an absence of a routine that would help promote sleep and wake consolidation. So I can imagine that in folks who are already vulnerable, this could lead to additional harms.
Oh, yeah. Oh, I love that. I've never looked at that. We should look at it.
Let's talk about it.
Yes, what a great idea. Very cool.
I have one totally irrelevant or unrelated question, but do you know Fred Coe?
Yes, of course.
He trained in our program here.
Huh?
He was like one of the best geriatrician fellows we ever had. We tried to keep him here, but he had to go to New York. So I'm glad you worked with him. He was a superstar.
Yes, he is awesome.
I'm glad you know him.
I miss him.
Yeah. Well, tell him to come back to Baltimore.
We could talk about that maybe.
Okay. All right.
All right. Well, thanks, everyone.
Thank you.
Thank you. Bye.